MWindy engine chill is complete.
AFTS is ready for launch.
Ground gas closeouts are complete.
Falcon Heavy is in startup. Stage 2 pressing for flight.
T-minus 30 seconds.
Launch director on countdown 1. SpaceX Falcon Heavy, go for launch.
Falcon Heavy is configured for flight.
T-minus 15, standby for terminal count. 10, 9, 8,
Side booster ignition.
6, 5, 4, 3, 2, 1, 0. Ignition. Off. Go Falcon Heavy.
Stage 1 propulsion is now.
Okay, good morning everybody, and welcome to the first webinar in lockdown 2020. I hope you enjoyed the build up with the launch of the Falcon Heavy test rocket by SpaceX. Currently we've got almost 400 people joining the webinar this morning. Just before we start, can some of you just message and let me know that you're hearing me okay? So some of you could just type a few words to say that everything is good and that you can all hear me okay. Excellent, thank you, Ali. So Ali's in the background, so every now and again I'm going to speak to Ali, who's my director. So hi everybody, I can see so many of you putting messages up. That is great. Okay, let's get this show on the road this morning. Thank you so much for joining in. We've currently got 450 people logged in. Okay, so Lockdown 2020 is a series of webinars on a range of primarily dental subjects. We also have a number of non-dental speakers where we have dentists with interests that they want to share with us. So for example, this afternoon, we've got Mike Gow, who's going to give a very informative chat on his knowledge of whiskey. And we have the absolutely brilliant and inspirational Nigel and Vicky Millen, who are going to talk to us about all the work they've been doing for years with Smilawi. Lockdown 2020 is open to all members of the dental team. So you're all very welcome to join in. Every single Lockdown 2020 lecture is going to be free. At various points, I'll point in the direction of a Just Giving page. Everything is free, but if you would like to contribute to the Prince and Princess of Wales Hospice, I will direct you to the Just Giving site for that. So everything's free, but donations very, very welcome. I'd like to thank our two main sponsors, Dentsply Sirona and Henry Schein, who are supporting Lockdown 2020. And I'd particularly like to thank Kirsty Payton of Dentsply Sirona for the support that she's given me over the past 18 months, and to Joanne Robertson at Henry Schein, who I worked with for very many years at Henry Schein, as I said. Okay, so you will be able to claim verifiable CPD if you're attending today's lecture, okay? You can't just get it if you register, you must attend. Just to let you know, and you're about to find out, there are going to be 3 online quizzes which you must complete in full, okay? That is the Just Giving website, and that gives me an opportunity just to send you a little link. So I'm going to copy that and paste into chat the Just Giving website. So you see in the little questions and answers, the Just Giving address. So let me just see if that looks okay. There we go. So if any of you want to donate to the Prince and Princess of Wales Hospice to support Lockdown 2020, all for charity, not a single penny is going towards any of this, it's all going to charity. Please go and visit that website. So a little bit about me. I work for a number of dental practices across Scotland, providing digital dentistry, oral surgery and implant dentistry. I work in some practices and mentor and support others. So that's enough about me. What I'm going to do now is to try and get some information about you. Obviously, I can't speak to you. I can see your messages, but there's too many of you to kind of do a chat thing with. So if you just message me any questions that you've got, and I'll try and answer. Ali Fraser in the background is also going to try and answer questions, or certainly write down things if I can't deal with them now. Okay, so let's do start with some questions about you. So question number one, just give me some background information on who you are. So there's 500 of you now have joined in. So who are you? Are you practice principals, associates? Do you work in independent practices or with corporates? You VDPs, community? Are there any dental students out there? I think I forgot to put a dental student option in. So dental students, just click other, okay? So I'm seeing, so the results are showing me that we've got 7% of you at the moment are practice principals, 50% of you are dental associates, independent practices, 13% are in corporates, we've got 20% thereabouts in VDP training levels. I'm assuming the students have clicked and maybe some of the others have clicked training levels. My apologies for not putting the dental students in. I'll remember to change that poll for next time. So I'm just going to close that first poll, again, just finding out a little bit about you. Then why are you here? Okay, so let's have a wee look at that. Okay. What is your current confidence level? Okay, and what's your current confidence level in oral surgery? So do you do no extractions? Do you refer everything? Do you do some simple extractions? Do you do complex extractions, or do you everything, no implants as well? So just we're up to about 520 now in the webinar, and I can see that the vast majority of you, about 56%, will do simple extractions but refer complex and surgical cases. Some about a third will do complex extractions and simple surgical cases, and there are some that will do some other stuff as well. That's great, excellent. That's very informative. So thank you for doing that second poll. And the final poll that we're going to run this morning is, let's just reset that. So one more poll for you all to take part in. What is the biggest barrier that you have to undertaking extractions in minor oral surgery? Is it a lack of experience, lack of equipment, medical legal anxiety, the fees are too low, it's not worth it, and you've got no support in the practice? So I'm just going to vote, if you all vote on that now, please. Okay, so just the results are all coming in. I feel it's a bit like news night on election night with the results coming in from all the constituencies. But I'm seeing that just under 60% of you feel you've got a lack of experience, and if the other things are spread fairly evenly between lack of equipment, medical legal anxiety, fees are too low, it's not worth it, and you don't have support if you need it. So that is very informative, and that fits in with what we found in the past. So last year I ran a series of oral surgery and modular courses and workshops at various different dental practices. And what we found was that in undergraduate teaching, undergraduates seemed to have a very limited number of cases. They maybe would do 10 extractions as undergraduates. When they went into VT practices, they maybe went into a practice where there were very few extractions done, or the practice protocol was to refer everything apart from very simple extractions. In some environments, there wasn't a senior dentist in the practice. There were associate-led practices, and there wasn't somebody senior who could help out. And this was the case both in independent and corporate environments. We know the fees are ridiculous in the health service. It's just a fact, and it's not an incentive to try and undertake a challenging procedure when it's sometimes easy to say, I'm going to refer you to wherever. Many practices don't have enough equipment to do more advanced procedures. People are worried about getting sued in the GDC. And quite simply, it's sometimes easier just to be not seen as a bad guy. Why? You don't want a patient to come back swelling and tell all their friends that you're a butcher when it's easy to send the patient to somebody else. So that's our goal. And so that's the fees for last year. I'm sure we all agree that these fees are not an incentive to undertake oral surgery. But let's be honest, the NHS is under pressure, as we can see. Turn on the news, and the NHS simply has greater priorities than dental treatment. And this isn't just a problem in the United Kingdom, but across Europe. There's papers showing that undergraduates are not getting the experience, and this is leading on to dentists not being competent and confident in doing oral surgery. Okay, so I hope you're all enjoying things so far. I'm about to send you a link in the chat. So I'm just going to go back into chat, and if you can all please now click on the link that I have just sent to you, because you're about to go back to first year dental school, and we're going to do a quiz for the next wee bit on anatomy. So I want to see what your anatomy knowledge is. Now, in order to get your CPD, you must complete the 3 quizzes, okay? So let's just bring up this one. So the first quiz is on anatomy. So I can tell you're all sweating, which is good. Right, so here we go. So any issues, just let me know by messaging, but I hope if can just all check on to all the answers to the poll to, okay. So if you could quickly, thank you. Some of you are giving me comments, and I'll save all of them and look at them later. If you could all click on the Microsoft Form anatomy quiz. Any issues? So the link's below, George, the link's below, I've sent it to you. Have you all got it? Has everybody got the link? I'll send it one more time. Photo still loading. Okay, so the photos should work. Just give it a little bit of time. The photos will work if you just give it time. It depends what kind of computer you're on. So the link is in the chat. So if you go into your chat, the link is in there. So click on the chat button. Some people have got the link, so you just need to find it. Okay. If you cannot see the photographs, what I'm going to do now is to scroll through the pictures. Okay. So the good news is that there's no negative marking. Okay, so question number 1, okay? So so it doesn't start at that, Lindsay, it's not question number 5. Question number 5 is actually anatomy spot test 1. So if you can all start on anatomy spot test 1, just look at the screen, okay? So ignore the questions, you can use the screen and just look at the presentation. So anatomy spot test 1, what is this structure, okay? Is it A, the geniohyoid muscle, B, the mylohyoid muscle, C, the anterior belly of digastric, D, the posterior belly of digastric, or E, the genioglossus muscle? Okay, question number 2, anatomy spot test question number 2. Which nerve innervates that structure? Is it A, the facial nerve, B, the trigeminal nerve, the nerve to mylohyoid, C, the cervical nerve, D, the laryngeal nerve, and E, the lingual nerve? Ali, Ali, maybe you can send the link directly to some people. You'll be able to do, once you've got this link, you'll be able to do the form later on, okay? Okay, so spot test number 3. What is this structure? A, the masseter muscle. B, the temporalis muscle. C, the medial pterygoid. D, lateral pterygoid. Or E, buccinator muscle. Okay, anatomy spot test number 4. What is its blood supply? A, posterior superior alveolar artery. B, the facial artery. C, the lingual artery. D, the buccal artery. Or E, the maxillary artery. Okay, I'm keeping on sending the link again, so I'm firing the link out to you if you've not got it. And the spot test number 5, what is this structure? A, hyoid bone. B, zygomatic arch. C, coronoid process. D, angle of a mandible. E, condyle. Okay, number 6, spot test 6. Which muscle inserts into this? Is it A, genioglossus, B, masseter muscle, C, mylohyoid muscle, not uncle, D, geniohyoid muscle, or E, sternocleidomastoid muscle? Okay, next one, spot test number 7. What is this structure? Is it A, the hyoid bone, B, the mandible, C, the cricoid cartilage, D, the hyoid cartilage, or E, the trachea? Spot test number 8. What is the main function of this structure? Does A, support the trachea, B, vocalization, C, retract the mandible, D, protrudes the mandible, or E, stabilizes the floor of mouth during swallowing? Okay, Amy, thanks for that. The link is at the top of the chat. So I was looking at the bottom, so tell everybody that the link is at the top of the chat. We have tested this many, many times. So hang on a minute. I'll send it again. Okay, what is this structure? A, the cervical artery, B, the lingual vein, C, the facial vein, D, the facial artery, or E, the lingual artery? Okay, spot test number 10. Where does this originate from? Is it A, the external jugular vein, B, the carotid artery, C, the lingual vein, D, the superficial temporal artery, or E, the cervical artery? Next one, spot test 11. What is this structure? Is it A, the facial artery, B, the facial vein, C, the pterygoid plexus, D, the cervical artery, or E, the facial nerve? Spot test number 12. What are its branches? Is it A, the temporal, zygomatic, buccal, mandibular, and cervical arteries? Is it B, the facial, mental, lingual, cervical, mandibular nerves? Is it C, the temporal, zygomatic, buccal, mandibular, and cervical veins? Is it D, the facial, mental, lingual, cervical, and mandibular veins? E, the temporal, buccal, mandibular, cervical nerves? Spot test number 13. Thank you, Farhan. I'm being far too polite to say that. I knew somebody like you would think that. Yeah, so we're all thinking back and trying to remember the mnemonic that we all learned in first and second year. Okay, spot test 13. What is this structure? Is it A, the facial artery, B, the lingual nerve, C, the lingual artery, D, the facial nerve, or E, the lingual artery? Thank you, Depeche. Anatomy spot test 14. Where does this originate from? Is it A, the branches from the external common carotid, B, the branches from the internal jugular vein, C, the branches from the external jugular vein, D, the pterygoid plexus, or E, the inferior vena cava? Mark, I can see there's obviously kind of max facts chat going on here in the chat room, so no showing off. Anatomy spot test 15. What is this structure? A, geniohyoid muscle. B, genioglossus muscle. C, mylohyoid muscle. D, platysma muscle. Or E, buccinator muscle. Spot test 16. I know I'm going through them really quickly, but they're all there in the link, so you can go into the Microsoft form. We'll give you some time to do that. Anatomy spot test 16. Which nerve supply is this? Is it A, the temporal nerve, B, the zygomatic nerve, C, the nerve to mylohyoid, D, the facial nerve, or E, the mental nerve? And anatomy spot test 17. What is this structure? Is it A, the superficial temporal vein, B, the iliacotemporal vein, C, the facial nerve, D, the superficial temporal artery, or E, the cervical artery? And from where does that originate? Is it A, the external carotid artery, B, the pterygoid plexus, C, the facial vein, D, chorda tympani, or E, the external jugular vein? Anatomy spot test 19. What is this structure? Is it A, the buccinator muscle, B, the mylohyoid muscle, C, the temporalis muscle, D, platysma muscle, or E, masseter muscle? And the last question, and again, you can go back into the Microsoft form and do this at your leisure. To what structure does this insert? Is it A, the orbit angle of mandible, B, the temporal bone angle of mandible, C, the temporal arch temporal bone, D, the temporal arch hyoid bone, E, the zygomatic arch oblique angle of mandible? If your pictures aren't loading, we've tested this. It's just the settings on your computer. We've tested these on PCs, Macs, everything. It's settings issues on your computer. Okay, so just give it a wee minute to reload. So Marion said, I refreshed the page and the images appeared. Okay, so the link is working. Just refresh the page and the images will appear. There's two more tests that aren't anatomy. One's on extractions and one's on suturing. Can you please leave the tab open for your anatomy test? Okay, I'm going to send that link one more time. Okay, you can come back and do it later. Okay, so that's just a little bit of fun. Okay, so that's it. Okay, so we're going to come out of the anatomy quiz. You'll all be glad to know. Was that fun, everybody? I know there were some wee technical issues, but the link definitely works. Okay, it all works. It's issue, and we need to just have a wee look at it. Okay, right. So let's get back to the presentation. So that was just to see your anatomy knowledge. And what we're going to now is to go in and learn a wee bit about the anatomy that's relevant to oral surgery. So if you just give me a little minute to bring this up. Okay, now that I'm back into difficult, Orla, yes, excellent. Was able to do the whole quiz and submit. Gillian, okay. So tough. Okay, so obviously working. If you're having any issues, so you got 12 out of 20. I did anatomy a long time ago. Definitely awake now. Thank you for keeping the messages coming in. Okay, can you all now see the basic science presentation? Ali Fraser, pass mark is 5. It is for you, mate. Okay, so basic science, can you all see the presentation and hear? Okay, yes, all good, right? Okay, so basic science is essential. It's something that we all did a long time ago, but the more oral surgery you do, the more you'll realize that you need to know your anatomy, you need to understand the principles of wound healing, you need to know about pharmacology, and you need to do, about medical history. This is stuff that we all learned some time ago. It was a long time ago, but we're going to just briefly revise this now. I'm going to whiz through so much basic science. Obviously, we could spend days and weeks on this. Okay, don't worry. There's going to be the anatomy thing is not just for. I'm sorry, Collie. The anatomy is relevant to everybody, as you're about to see. Okay, so I'm going to show you why I wanted to do the anatomy quiz. This isn't just for dental students; it's for everybody. Okay, so everybody needs to understand anatomy, and I'm going to show you why right now. So we spent a lot of time studying the anatomy of the head and neck. But some of you might forget about it. But if you're wanting to do oral surgery, whether extractions or implants, you need to know the anatomy, okay? When you need to think about where you're working, not just the teeth, the bone and the adjacent anatomy, okay? In the anterior maxilla, okay, the bone is very thin in the aesthetic zone. This is incredibly important to those of us working with implants. You need to know about the canine prominence. If you think about the anatomy and the bone in the canine prominence, then you'll appreciate why it's more difficult to do extractions of the canine. Look how close these teeth are to the floor of the nose. Where's the position of the incisor foramen? A lot of people think that if you cut the incisor foramen, the patient's going to bleed to death. That's not going to happen. But if you know the anatomy, then you'll be fine. So anatomy is essential. When you extract teeth, the bone resorbs, and the pattern of resorption, as described by Atwood and Coe, is different in the maxilla and the mandible. But for those of us doing implants and bone grafting, and then if you go on and you're doing more advanced procedures, then for sure you need to understand the resorption patterns in both the mandible and the maxilla. In the posterior maxilla, it's different to the anterior maxilla. You've got a thin buccal wall. You've got the sinus floor is very close. The tuberosity is there, and you've got the palatal blood vessels. So this is a case. Now, I want to point something out here. I am just a routine general dental practitioner. I've never worked as an oral surgeon in a hospital ever. All the skills I have learnt over the past 30 years in oral surgery, I have learnt in general practice. So whether you're extracting a tooth or doing sutures or dealing with cysts, these are all skills that I believe if you learn and study and invest time in, any general practitioner can do that. What concerns me is we're now in a situation where many general dental practitioners can't extract teeth. And I've always really stressed the importance on oral surgery with all my VTs and young dentists over the years. So as you can see in this CT scan, look at the extent of the bone loss around that lateral incisor and look at the proximity to the nose. And you wonder why we need to know about anatomy, because we're so close to the nose. And you can see there the extent of the bone loss. And I'm going to show this picture later on, because when we look at flap design, this is really, really important. So I'm going to come back to this picture later on in the presentation. Just a few messages to me. Everybody getting this okay? Am I coming across clearly and are the slides clear? Again, pathology. Let's not forget the pathology. Anatomy is important, but we've got to remember our pathology. Look at the radicular cyst on that tooth. So can we just get a few messages just to let me know that everything's coming over okay? Yes, good, good, good. All clear, fantastic. Okay, so I was removing a nasopalatine cyst. Okay, so there we've got to think about the incisor foramen. But wow, look at that. What is that? The arrow. So you don't need to be a genius to realize that's the floor of the nose. That nasopalatine cyst has destroyed all the bone, and that lining is the lining in the floor of the nose. Okay, so this is why if you're going to do oral surgery and advanced neurosurgery, you must know your anatomy. Okay. And what we've done there is I've put a membrane over the defect to cover the floor of the nose. Again, there you go. I've been doing some surgical procedures here, and look at that, the incisive foramen and canal. Now, I've carefully dissected that, but if you cut through the incisive foramen and canal, the bundle, the patient will bleed a wee bit, but it's not a vital structure. The bleeding will stop, and there may be some minor sensory disturbance, but it's not a key structure. And a lot of dentists think they can't take teeth out there because of the incisive canal. Not the case. Again, in another procedure, we're removing this weird didontic implant from 50 years ago. You can see, look at the flap design, and we'll speak about the flap design later, but again, we're in the area of the incisive foramen. Posterior maxilla, you can see here. Look at the proximity of the roots of that upper premolar to the sinus, okay? And what's happened here is that on extracting the tooth, the dentist has put that root into the sinus, okay? Fortunately, I wasn't too far away and was able to go in through a lateral window and fish that out. So again, you need to be aware of the anatomy, where the sinus is, if you're doing extractions, and certainly if you're going on to do sinus augmentation. Side, you can get some temporary sensory disturbance. So in the incisive frame, and if you cut through it, it's no big deal, and it's not significant. I've never actually had any issues with it. Okay, I'm going to show you other nerves very shortly that you aren't as forgiving. If I see questions coming, I'll try and answer them. Okay, but can't do everything. Depeche, there's not 24 questions. The first four questions are your name. Okay, so name, address, name, email address, etc. The first four answers. There's 20 questions. Okay, and again, lateral window. Now, what's interesting here for those of you that aren't experienced and working in the sinus area is that in order to get that root out, I had to drill through not just the bone, but the sinus lining to fish the root out. In a sinus augmentation procedure, we leave the sinus lining intact, and you can see on this arrow a branch of the posterior superior alveolar blood vessels. And this is significant because when you're working in this area, you can get significant bleeding, but it's not life-threatening bleeding. Okay, so again, this is anatomy that you need to know if you're going to be doing surgical procedures. We can see on the CT scan, the circle is where we're creating a window, either to get a root out or put bone in. But if you look at the arrow, you can see there's a dark area. I'll maybe try and just bring that up with this. Let's see if we can get the whiteboard to work. This is just a chance for me to practice in the whiteboard. So the whiteboard, but it's in black. Let me change the color. Just checking my whiteboard's working. Whiteboard working? Yeah, okay, so that little dark circle, okay, is the blood vessel, okay? And if you're going to drill through bone, you need to be aware where these blood vessels are. Of more significance in the posterior maxilla and the palatal area are the palatal blood vessels. If you're doing soft tissue grafting and soft tissue surgery, you need to avoid these, because if you cut through one of these blood vessels, then you could be getting either an ambulance or getting that patient to accident emergency pretty quickly. So unlike the incisive foramen, in the posterior palate, there are blood vessels that you need to be aware of and avoid. Hello, Rory. Looking forward to your tips on running. Okay, switching to the mandible. Okay, again, significant anatomic features there that we need to be aware of. Okay, so if you're taking out wisdom teeth, if you are doing coronectomies, you need to be aware of the position of the inferior dental nerve, and also bear in mind the lingual nerve, because both can be damaged in surgical procedures in this area. This isn't a lecture about wisdom teeth or CT scanning, but increasingly we are taking three-dimensional imaging in order to assess wisdom teeth extractions. Again, CT scanning, we use it routinely for implant planning, and as I said, increasingly for wisdom teeth extraction and doing helping decide whether we're going to do a wisdom tooth extraction or a coronectomy. Okay, so what I need to do now is just to jump into a little video, so give me a second. Okay, no, we won't come into that video because I didn't upload it. I'll upload that after break time. Okay, so this is a residual cyst in the mental foramen region. So if you look here, we can see we have a retained root. So we've got a retained root there, okay, and we've got the residual cyst here. And what anatomic feature have we got going all along here? So we need to bear in mind the position of the mental foramen and the inferior dental nerve when we're removing this residual cyst and that root. And you can see we've managed to extract the root and that residual cyst without causing any nerve damage. And many of you will not have seen the mental foramen before. And what's significant here is, let me just show you this. I'm going to bring the whiteboard up. So this is the mental foramen here, okay? And by having a vertical incision anterior to the mental foramen and then blunt dissecting, we can expose and protect the mental foramen, which is something that we do routinely in implant dentistry. But it's also important if you're needing to take out do an extraction, you need to bear in mind here. So it doesn't matter whether you're doing an implant here or an extraction here. You do not want to be doing a vertical relieving incision through here, okay, or the patient will be left numb. So the mental foramen and the nerve there isn't something that you should be afraid of. You should be confident in knowing where it is from your x-ray, and you can see that on a two-dimensional x-ray. You don't need a CT scan, and then you can razor flat, having a vertical relieving incision anterior to it, and making sure that you carefully, if you need to go that and find it, that you protect it, okay? So this is why anatomy is so important. And if you know where these key structures are, and if you're confident in locating them, then you're not going to worry if you have to go and do a surgical extraction. So this is important, not just for implants, but for simple surgical extractions as well. So anatomy and pathology are the key to oral surgery. If you don't know your anatomy, you don't know your pathology, you can have all the technical skills in the world, but you shouldn't be doing it. And that was the reason why I did the anatomy quiz, just to make you think a wee bit about the importance of anatomy. You'll be glad to know there is not a pathology quiz, unless you want one for Anne and our Max Facts colleagues who are watching. Let me just get the whiteboard off. And obviously, just turning our attention to the teeth themselves, we need to think about the root morphology of the teeth. We need to look at curved roots. So again, whiteboard up. So curves in the roots, that's a challenge, okay? But this is good news, look. That's more easy for us to deal with, okay? Are we perhaps going to have a tooth with, like this one, are we going to section the roots? So we need to bear in mind how we extract teeth based on the root morphology that we can see on our radiographs. Okay, that's excellent. So I'm just going to jump back into the next slide, if you give me a second. Right, I'll need to just move myself because I'm in the way. Okay, so can everybody just get a quick message from everybody? Can everybody see the next? Michael, what is blunt dissection? I'll come back to you on that. Can't answer. I'll come back to you there. It's a technique where you use you don't use sharp instruments, and you very carefully, using gauze and things, take the flap out there. So everybody can see the next presentation. Okay, so we're going to talk just a little bit about socket healing. Again, we've not got time to go through the whole process of wound healing. When you extract a tooth, there's hemostasis, the body's defense mechanism to stop you bleeding to death. There's inflammation, your body's way of preventing infection. Proliferation is the creation of cells that rebuild the wound, and remodeling is the body turning over the cells in the wound and creating new tissue, whether that be bone or soft tissue. So that's wound healing in one slide. Again, in osseointegration, spelling mistake, so hang on a minute. Let's start here. Okay, so osseointegration, we're not going to talk about implants, but stages are osseoinduction, osseoconduction, and osseoadaptation. This isn't an anatomy chart. Okay, so relevant medical history. This is something else that everybody gets very excited about, and is a reason why people refer patients. So many of our patients have complex medical histories. They may have bleeding disorders, or they may have been medication. They may be on bisphosphonates. They might have had a heart attack. The ABC, the antibiotic cover yo-yo. Okay, when I graduated in 1993, we were all get 3 grams of amoxicillin, clindamycin to patients in all these categories, and then it was all scrapped, and now it's back in. And I can't give you a definitive answer on that, because guidelines just seem to change year in, year out with antibiotic prophylaxis. Diabetics, type 1 and type 2. When I graduated, there weren't as many diabetic patients as we see now. Every other patient, I think, over the age of 50, 60, if they're overweight, is probably maybe on metformin. And something that I think we don't pay enough attention to is the patient's mental health. Okay, and I'm going to talk a wee bit about that as well. So obviously all of these subjects, everybody still hear me okay? Just a quick yes from you if you can. One person said they've lost the connection. Thank you, Ali. Yeah, okay, cheers. Okay, so we could spend a lecture a day talking, thank you, Smita. We could spend a day or a lecture talking about any one of these individual subjects, okay? But obviously we can't do that. So I'm going to whistle-stop tour of these Bleeding disorders, okay, one slide, okay, so I could get everything into one slide. Patients on medication, warfarin, aspirin, clopidogrel, the Pixies or the Novo drugs, alcoholics, hereditary issues. I can't talk about all of these. I'm going to just share with you now the guidelines and a summary of these. So give me a wee second. Files. Okay, you should all receive a sharing link for the SDCEP guidelines on managing patients with bleeding issues. So again, if we can just jump back into chat, can I just check that you're all getting a link to download these guidelines? The point that I'm going to make here is that you cannot not see patients who are on aspirin, the new Novo drugs, warfarin. There's so many of them, okay? And if you have a look, the link, some of you are getting a link, so it's there, so you should all get it. Can't really turn them away. I've been, you know, I do implants on patients in warfarin. We do implants with proper medical assessment on patients with all these drugs. You just have to assess them and follow the guidelines. Look at the guidelines; they're there to help you. Okay, these bleeding issues should not be a reason for referring. Now, obviously, if somebody's a haemophiliac or has some very significant bleeding disorder, then yes, refer them. But if they're taking aspirin, follow the guidelines. The link is there, so if you go into the chats or somewhere else, it's the link is definitely being shared. Most of you seem to be getting it okay, so it has to be there and it's being shared. Okay, Emronge, patients on bisphosphonates. Let's see if we can get a wee video.
Fosamax is a medication primarily used to promote bone growth in patients suffering from osteoporosis. According to a recent study, Fosamax has been linked to the degenerative bone condition commonly known as dead jaw. Symptoms of dead jaw can include exposed bone, loose teeth, and significant chronic pain. If you or someone you know have taken Fosamax and experienced unexplained jaw deterioration, call Norris Injury Lawyers 1-800-REAL-LAW.
And anybody wonders how they managed to elect Donald Trump as president. Sorry, don't do politics, Clive. Okay, so that was obviously a scary video from the States where there's obviously some ambulance chasing lawyer. But let's just go back into where we were. Okay, so lots of patients on bisphosphonates. Again, there are SDCEP guidelines, which I'm going to share with you. Okay, again, you should now all be getting the SDCEP guidelines on bisphosphonates. Can you check? Again, a couple of messages just to let me know that you've all got those guidelines. So as you know, that patients can either be on oral bisphosphonates or IV bisphosphonates. Okay, and I'm comfortable within the guidelines treating patients for extractions where required on oral bisphosphonates. We'll tell them, we'll give them information, and we'll consent them. The same will apply for implants. Again, following the guidelines, it's not an absolute contraindication. Intravenous bisphosphonates is a different matter. And I think if a patient is on intravenous bisphosphonates, again, you need to talk to the patient about it and risk assess. But I would not be comfortable doing implants in patients who are currently on IV bisphosphonates. I have done implants on patients who have previously been on IV bisphosphonates and stopped it. Again, I don't want to talk in detail about this. I just want to give you the information on SDCEP. and I'll let you think about it. But you shouldn't, if a patient comes in and says they're on alendronic acid, you shouldn't panic, okay? You should risk assess them following the guidelines. Depeche, I can't answer questions. I'll go through the chats and come back to you. Antibiotic prophylaxis, as I said, it's a yo-yo protocol du jour. So I'm just going to skip over that because, quite honestly, I don't know the answer. Smoking. Next couple of slides. Would you do a simple extraction in patients in IV bisphosphonates? In an emergency, if I had to, if the patient's having severe pain and there's no option, then yes. If you could avoid it, then no. Smoking. We all know the risks of smoking. Smoking interferes with healing. Anybody that's done an extraction will know that a smoker doesn't heal as well. It's not a contraindication to an extraction. It's not a contraindication to implants. But I have colleagues who will certainly not do more extensive procedures on smokers. Fran, I know you're watching. Fran does zygomatic and pterygoid implants. In fact, Fran's going to be doing a presentation next week on pterygoid implants. Came and assessed a patient of mine, heavy smoker, you're not getting zygomatic implants. Okay, and one thing that I think is completely, ignored, not ignored, but doesn't get the attention it deserves amongst undergraduates and dentists is our patients' mental health. Let's put aside our own mental health, but let's talk about our patients' mental health. We spend lots of time, looking at bisphosphonates and bleeding disorders. But what about all our patients are coming in on they're on citalopram, sertraline? These are widely used drugs, plus a wide range of other ones. And this is something that I've kind of been concerned about because in implant dentistry, where I've had some issues in the past, very often looking back, sometimes it's communication, but there's been mental health issues there that I kind of not looked at. And one thing that I've started to use, again, thank you very much to Farhan, who I was running with this morning. We started off 2 meters apart, but because I was so slow, we ended up being 50 meters apart. I digress. Farhan and his group doing pterygoid and big implant, zygomatic implants, big implants, they have got a psychiatric screening for patients having major implant treatment, full arch implant treatment. It's a modification of the GP's anxiety and depression survey that you use. If you go to your GP and you've got anxiety and things, I'll give you this question hand out. The form that Farhan has got is a modification of that, and I think it's really, really useful. And I think we should all be paying more attention to what's going on up here, as opposed not just the other medication that are on for hearts and bones, etc. Again, I'm not going to go on about local anaesthetic, but obviously the main anaesthetics that we use are lignocaine and articaine. I don't really use Cytonist. We've got it in the practice for occasional use in patients that have significant reactions to adrenaline containing drugs. Again, anatomy. You can't do local anaesthetics without understanding the anatomy. So that's why I read the anatomy quiz at the beginning. It's just to get your brains thinking a wee bit anatomy, because you need to know your anatomy and your pathology and your pharmacology and your medical stuff so that you can do oral surgery with confidence. Yes, we're going to come on to the technical skills later on, but we need to know the basic sciences. Ali Fraser, I use Cytonist for all IDBs. Do you? Okay, sedation. Again, this isn't a lecture about sedation and managing anxious patients. Mike Gow, as well as doing a discussion on whiskey, is going to be talking about the management of anxious patients. We use sedation for managing patients who are having significant procedures such as implants and oral surgery procedures to make it easier for them. We're not seeing as many patients who have got anxiety issues. We use it more to help them get through bigger surgical procedures. Okay, just a quick spot question. These are 3 drugs used in combination. Can anybody tell me what they are used for? Midazolam is one of them. That's what I take before starting my surgicals. So what are these 3 drugs used for? I'll give you a clue. They're a special form of sedation. That's right, Mike. Exactly. So they're used for, if I give you a clue, it's used in certain states in America. Have you all got it? Yeah, this is the combination of drugs used in lethal injections, midazolam being one of them in some states. Okay, just starting to move away from the basic science into some more practical stuff now. Okay, so we're about a third of the way through. Right, so your patient comes in, and a lot of you have said that you're not confident in doing surgical extractions or more complex extractions. So I want to get, this is where I want to get you to start thinking about things and having a battle plan. So we've spoken about the importance of understanding the basic sciences, and we're going to look at the technical skills and suturing as best we can online. But now I want you to just think about a kind of battle plan for how do you know when this is an extraction that you can deal with confidently or when you've got to refer it. So what I want you to do is just think about, is the extraction planned or unplanned? So have you got the patient booked in for an extraction? So you've got more time to think about it, to plan, or is the patient just, you've got to extract it there and then? Is it an easy extraction? Is it grade 3, grade 2, grade 1 mobile, periodontally compromised, and you should get a tooth out easily? Or is it going to be more challenging? Have you got a radiograph? It really concerns me when we get referrals for patients whose teeth are even simple wee roots that are really loose, or teeth that have got grade 2 or 3 mobility and the dentist won't take them out. The patient has said to me, why can't my dentist do this? And I go, why can't they? Now I get it if it's a wisdom tooth, but for simple extractions, I don't see why dentists are referring simple stuff. Okay, and what I want to try and do is to give you the confidence to certainly be doing simple extractions, and at least having in your mind a plan for if that simple extraction becomes a more complicated extraction. Okie dokie. So radiographs, okay. Preoperative radiograph. Should you always take a preoperative radiograph for an extraction? That's a discussion. We can't have that discussion really over the internet. That's better for a group discussion. I think it's very useful to have a radiograph. I think it's a good medical legal record, even if the tooth is mobile. Because why do you take the tooth out? Because there is no bone around it. Periapical is fine. Okay, many practices will only have 2-dimensional imaging, intraoral imaging, and a periapical is absolutely fine. If you've got an OPT in the practice, that may be appropriate as well. And for more complicated extractions, impacted teeth, more and more we're using cone beam CT scans for patients that are referred in. Yeah, so just jumping back. So Rebecca's saying I always take a periapical. Yawa's saying yes. Alex is saying that you wouldn't take anything out without a radiograph. So the feedback that you're giving me in the chat seems to indicate that most of you would like to have a periapical before doing an extraction. This is a useful assessment where you grade the teeth and then you've got treatment options based on the grading of it. What I'm going to do is I've not put this in the shared documents. We're going to be having a break at about 11:30. So I think I will share this with you. But what it does, and there are other guidelines from endodontists, is there are treatment options for compromised teeth. You've got a decision guide. Are you going to root treat the tooth? Are you going to extract? Are you going to do an implant? Are you going to do an immediate implant? Is that extraction something that you're going to be comfortable with? Can you manage it if things go wrong? Just going back, so Marta wouldn't extract without a periapical. Always do a periapical unless it's very mobile. So most of you want to have a radiograph, which is interesting. So be prepared, okay? Whether you're doing a surgical extraction or just a routine extraction, you need to have good suction and good lighting. You need to have all the equipment ready, not necessarily in the surgery, but available. I can't stress the importance of having good suction. If a nurse, if I'm doing an extraction and a nurse gives me one of these large volume, big wide aspirators, that's useless. You don't have to have you just have a narrow suction, okay? It doesn't have to be a £2.50 a shot surgery tip. It can be a cheap, disposable, narrow suction. You need to be able to aspirate the blood out of the way so you can see what is going on, okay? You need to, if you're getting any extraction, you need to have access immediately to narrow suction if the tooth breaks, so you can get the blood out of the way and see what's going on. Suction and light are more important than anything else, apart from, of course, having a wonderful dental nurse working with you. And I need to at this point say that I'm very fortunate, because I know some of them will be listening, that in all the practices that I work in, I am blessed to be supported by the most amazing team of dental nurses. They are essential, and you need to have a good dental nurse working with you if you're going to be doing oral surgery. You might well be under time pressure. If you have got a rammed appointment book, okay, you need to make a decision. Are you going to take the tooth out now or get them back? If you're wanting to build up your confidence, then so do I use loops regularly for extractions? I use loops regularly for everything. What time does it finish? 1 o'clock. Eleanor, that's a good question. I've just been asked, what time does it finish? This finishes just before 1 o'clock. It is recorded, okay, and you will all get a link where you can go and watch this later on. All right, so going back, so nurses are wonderful. Absolutely, we have brilliant nurses, absolutely the best nurses anywhere in all the practices that I work in. I don't think anybody can have nurses as good as mine. I'm maybe sounding a bit like Donald Trump. I'm sure Donald Trump has got brilliant dental nurses. We can't survive without dental nurses. This is a challenging time for all us dentists, and I know that many of the dental nurses out there may be being furloughed. So I hope you're joining in and enjoying the CPD as well. And we're going to have nurse CPD for the nurses as well. So me too, amazing dental nurses at my practice. So can we get some messages up there? A big shout out to all the dental nurses, because we sometimes don't give them enough love, especially the ones in all my practices that I work in. So time, getting back to time, give yourself enough time. I know that's easy to say when you're in a busy NHS practice. If you don't have enough time, get the patient back. Okay, if you're having to do a surgical extraction, cancel other patients, just say, I'm sorry, I've come up with a problem. Give yourself time. Don't put yourself under more pressure. I don't like you giving them love. My nurses are, okay, see, my nurses are lace. Big love to the dental nurse team. Too true. 100 degree read, good dental nurses. You need to have good dental nurses. So make sure you've got the time there. Do you have the support in the practice so if something goes wrong or you need help, you can go and do that? I love being in practices where I can go and give help. or I can ask for help. Now that help might just be bouncing ideas around. So even an experienced dentist like me, it's quite good to say to one of my colleagues, well, what do you think about that? So it's, you know, I know it's not easy if you're in a practice where you don't have that experienced support there. I'm happy to mentor and encourage you, because I really think we need to get dentists confident in extractions and oral surgery. Big shout out to the nurses. Shout out to 146 Dental Care nurses. I feel a bit like a DJ actually. Dundee, Alex, our dental school nurses are helping with COVID testing in hospital. Amazing people, absolutely. So anybody that's helping out at the moment, they're moving over to help and support the NHS, or they're volunteering. That's absolutely fantastic. You're going to be on a learning curve. You need to work within your competency. You need to have mentoring, and you need to kind of go on a pathway. If you're not doing oral surgery, I don't want you jumping in and doing nasopalatine cysts and impacted wisdom teeth and coronectomies. But what I do think you should be able to do is to say, right, I want to be confident to take these roots out. I want to be confident if my tooth breaks that I can section it and take the roots out. I want to be confident in doing simple 8s. If you refer everything, if your approach to oral surgery is to refer everything, you're never going to learn. So you can develop your skills working with your competency and mentoring, but do that step by step. And consent and records, again, I'm trying to arrange somebody to come and talk from one of the defence organisations on lockdown 2020. Written records, written consent rather, notes, post-operative advice, verbal and written, are essential. I'm a big fan of custom screens for both assessments and treatment. Custom screens are available in SOE Exact, Systems for Dentists, R4. I'm a big fan of custom screens. Okay, so if you can just give me 1 minute, and I'm just going to jump into the next section. Everybody, just going back, Elaine, Gorbo nurses are great. I appreciate the team at Bannockburn. Dental nurses are fantastic. VT would be impossible without good dental nurses. Big up to the team in Inverness Dental Clinic. Yay. Okay, right, give me a minute. Okay, so just going to check another couple of messages from all. That's in the next part of everybody still seeing everything okay? If you've lost the connection, it's just because I've changed slide. Let's try that now, give it a second. Can people hear me again? Yes, yes, yes. Okay, so connection's back. Okay, good to go. Right, so some more practical stuff. Okay, so simple things like choice of forceps. Have you got a good range of forceps in your practice? Now, I've brought a whole load of things back from the practice. Ali, I know you're watching. I promise that I will bring them back straight away. Everything's going to come back to the practice. Don't worry. Okay, so make sure you've got a good access to a choice of forceps. Position, I can't really demonstrate it now, but make sure you're comfortable and the patient's in the right position for doing an extraction. It makes all the difference. Frozen still. Just try and refresh your screen. Most people are working. Okay, you've got your forceps. So again, I think most of you have got it. Some people are just saying it's frozen. Okay. So luxators and elevators. This is something that I have a bit of hobby horse about. Luxators and elevators, okay. Undergraduates seem to, it's like some, we can't give undergraduates access to these instruments because they can't take teeth out with forceps. So then they don't become confident, they go into practice and not confident in using them. So I'm going to speak a wee bit about the difference between elevators and luxators. So elevators, okay, are used to elevate the root in the tooth. There is a blade, a shank, and a handle. There's straight ones, such as straight Warwick James, triangular ones, such as Cryers, which come in pairs, right and left. There's pick types. I just need to move my picture out of the way so I can see my notes. Okay, they use a lever action and a wedge action. They can be used in different ways: a lever action, a wedge action, and a wheel and axis action. Now, what's important is that these are designed to use a lever or a wedge or a wheel and action, axis type action. If you use a luxator, if you think that a luxator is the same as an elevator and you use it with a lever action or a wedge action or a wheel and axis action, you're going to damage your instrument and damage the patient. Okay, so you must know the difference between an elevator and a luxator. One of the practices that I work in, they've got you ask for a luxator and they pass you elevators. So we're actually just buying a set of luxators. If I was stuck on a desert island and I was opening an oral surgery extraction clinic, I would want a set of luxators before forceps. So rules: don't use the adjacent tooth as a fulcrum unless it's also to be elevated. Okay, and I'm going to be quite honest, about 18 months ago, I got a patient sent in, needed an upper 6 extracted, sent in a last patient on a Friday afternoon. So I got the 6 out, but I damaged the 5 as well, and that patient has an implant. And I'd done the implant, I made a mistake, put my hands up, and I've sorted the issue out. But don't use the adjacent tooth as a fulcrum unless it's being extracted also. Always use finger guards as protection against slipping. I'm not sure if my former VT Martin Ritchie, Martin, I don't know if you're saving lives somewhere or if you're, I can't log in. Martin, if you're there, say hello. But use a guard to protect against slipping. These go into the floor of the mouth, it can be very nasty. And I'm quite happy to share with you our critical incident report that we had. So make sure that these don't slip, okay, because they can cause a lot of damage if you slide and go into the tongue or the cheek or something like that. So you use control. I mean, it's difficult to demonstrate, obviously, online, but controlled pressure. Okay, it's not like that. Controlled pressure. If the instrument's got a concave or flat surface, it should face the root or the tooth to be extracted. Support the buccal bone with a finger. You want to try and protect the bone that's there. Okay, and don't use these instruments blind, particularly in the posterior maxilla, because what will happen is you'll put roots up into the sinus and then you'll have to send them over to me and I'll have to go and dig them out, and I'll be the hero and you'll be the bad guy. So don't use these instruments blind in the posterior maxilla. Isabel, you'll get the link to the recording of the webinar later on. So luxators, okay. So luxators are not the same as elevators. I'm just going to open a couple of luxators. Just brought one home. So luxators, okay, what are the differences? Luxators are thinner and sharper than elevators. You can't really see it here, okay, but these are much, much thinner, okay. So that is, I don't know if you can see that, that's the elevator, and that's the luxator. So luxators are thinner and sharper than traditional elevators. Who can hear me? Some of you are saying we've lost sound. Let me just see if that's old. Can everybody hear me okay? Not sure? Okay. Right, so the luxators are used in a completely different way. They are used and are efficient at cutting the periodontal ligament. Okay. Yeah, reconnect, all fine. Yes, yes, all good, yes, yes, all good. Okay. Sometimes you're going to get messages from people saying that they can't hear. I need to get messages from others saying that it's all right. So they're efficient at cutting the periodontal ligament I use these in virtually every extraction. You know, perhaps not if the tooth is grade 2 and grade 3 mobile and you can almost take it out with your fingers, but luxators are so important, particularly when you're doing atraumatic extractions. They cut the periodontal ligament, you use them in a carefully controlled cutting motion, applying apical pressure to separate the tooth from the rounding bone and periodontal ligament. It is not the same as an elevator. Okay, take home message from this part is luxators and elevators are not the same. Don't apply any torque to the tooth root with a luxator. You're using it to cut around the periodontal ligament. If you use them incorrectly, you will chip and break luxators. So often I go into practice and the luxator tip is all chipped and broken, and that is because it's been used as a luxator and not as an elevator and not a luxator. So traditional elevator okay. Equipment. So just looking at, we're going to spend a little bit of time on complications. Just to let you know, I'm planning to have a 10-minute break at 11:30. So if you want to go and put the kettle on, leave your browser open. Okay, 10-minute break at 11:30, and we've also got a special presenter coming in. Charlene Jones is going to be doing a 10-minute yoga class. So if any of you want to join in with a 10-minute yoga class, you're welcome to do that, or go and have a tea or coffee. Okay, so complications, fractured tooth. That's why you're here, many of you, because you wanted the confidence to learn how to do surgical extractions. Infected sockets, uncontrolled bleeding, fractured tuberosities, fractured alveolar process, damage to adjacent teeth, putting the root into the sinus, and fractured mandible, nerve damage as well. So again, we can't go through all of these in detail, but just some salient points about each. Infected sockets, use local anaesthetic, curettage and encourage the bone to bleed. I don't use things like Alvogel, it's in the practice, and the guidelines are not to use antibiotics unless there are systemic complications. Local anaesthetic in and get the socket bleeding. Bleeding, okay. Lindsay again, can we record it? It is being recorded. You will get a link later on. Local bleeding, local anaesthetic in, pressure with gauze. We're going to speak about using sutures, either horizontal mattress sutures or cross sutures. You can use things like bone wax, collagen sponge. Key is to give the patient emergency contact and advice in case the bleeding doesn't stop, and then get them back to review them. So there's two kind of situations. One is where the patient's not, the hemostasis hasn't achieved as quickly as possible, normal in the surgery. So you can put pressure on, more local anaesthetic and put in a suture. Or you might need to get, if the patient comes in later on and phones in and said, I'm bleeding, then you still need to do these things. But again, we should all be confident in doing sutures. One of the key reasons that you need to all be able to do a simple suture, either interrupted horizontal mattress, is to manage bleeding. Nerve damage. Everybody thinks an awful lot about nerve damage in wisdom teeth, but be surprised the number of times that the roots of molar teeth, particularly second molars, are adjacent to the inferior dental nerve. This patient came in with having to get the retained roots of the 7 out, and we took a periapical to begin with, and then an right OPT. And as you can see, the wisdom tooth 4-8 is well clear of the nerve, okay, but the roots are of the 4-7 are very close to the nerve. So again, another reason for taking a radiograph. If you're doing anything, take a radiograph. Fractured mandible. This patient came in. Are you, Lorraine, are you there? I'll just say, I don't know if Lorraine from Clydebank is joining this morning. This is a case that you'll remember well. I think you saw this in about day 1 or 2 after you arrived there. Patient came in with what we thought was just an extraction, but we can see the alveolar process here. So you can see this. This is the bone where the mandible is fractured. So the patient came in concerned about this. This was a clue that something was going on, and there's a bit of a backstory to this, as there always is. But we took an OPT, and you can see the fractured mandible there. I don't work in Clydebank anymore, but I don't think I've ever seen as many fractured mandibles as I did in my time in Clydebank. I'm going to whiz through immediate implants because it's a subject in itself, but bear in mind that just talk to your patient and speak to your implant dentist, whoever it is. The patient might be suitable for an immediate implant, and you can do immediate implants in molar teeth as well as single-rooted teeth. So an immediate implant is when the implant is placed at the time of extraction. If it's a single tooth, it's unlikely to be loaded. I'm not going to get into the whole immediate loading thing, but I just want you to think about, before you extract the tooth, say to the patient, are you thinking about getting an implant? How are you going to replace the tooth? And you can do an immediate implant 6 weeks after you've had the tooth taken out. But if you're thinking that the patient might be interested in an implant, get on the phone or message whoever you work with implants to get some advice. Okay, so we've got 10 minutes to go, and the good news is that before the break, we're going to do the one more quiz, which is the extraction quiz. So let me just get this up. Okay, I'm going to send you all the link for this quiz, and if you want, you can do this quiz during the break if you're not doing yoga or going for coffee. So give me a little second to get the... So if you all go into your chat board, you're going to see the link coming in a second. Everybody seeing the link? Okay, I've sent the link. Can you just send me a message to let me know that you've got the link to the extraction quiz? Do you want to build a snowman? Let it go. I'm obviously not in the loop. What is this? Do you want to build a snowman? I've obviously missed something. Can we record this webinar? I've answered that already. Back online, okay. Right, okay, so again, this is all on the Microsoft form. There's less images, and the images are not crucial apart from the two things. So question number one, a 40-year-old male. I'm going to actually just let you take your time to go through these at the break. Question number one, a 40-year-old male presents with severe pain related to a grossly decayed, unrestorable lower left molar. He's a poor oral hygiene and a neglected dentition. He smokes 20 cigarettes a day but is otherwise fit and healthy. You carry out an extraction of his lower left 6 under local anaesthetic using forceps alone. Which one of the following complications is most likely? Okay, so I'm not going to go through all the answers because they're on your questionnaire. Excuse me a minute, my cat's trying to get into the window. We'll be back in a minute. That's the first time I've ever presented and had to let my cat in. Okay, so question number one. Have you all got the link? Yes, just going to put it up again in case you've not. Okay, question number two. 70-year-old male patient requires extraction of her lower left second molar. She has a history of osteoporosis and is taking oral alendronate. You're concerned about the risks of bisphosphonate-related osteonecrosis of the jaw. Which of the following factors is least likely to increase the risk of complication in patients taking bisphosphonates? Question number 3. A 60-year-old female patient requires extraction of her upper right first molar. She has a history of ischemic heart disease and is taking oral warfarin. You're concerned about the risks of post-extraction bleeding. Which of the following is least likely to aid hemostasis? Question number 4. A 45-year-old patient develops an oral antral communication following extraction of her upper left first molar. Following surgical repair of the defect, you provide post-operative advice to this patient. Which one of the following precautions is least likely to be included in your instructions? Least likely. Question number 5. Displacement of a tooth into the infratemporal space is most likely to be associated with which one of the following teeth? Question number 6. You plan to carry out extraction of a lower left first molar shown in this radiograph. Which one of the following factors is most likely to increase the risk of fracture of the tooth during the extraction? Question number 7. You have carried out a tooth extraction on a patient taking warfarin. Which of the following is most appropriate measure to achieve hemostasis? Question number 8. You are taking out a lower right second premolar tooth using extraction forceps. Which one of the following movements is most appropriate to minimize the risk of crown fracture? Question number 9. You plan to carry out extraction of an upper left molar, first molar tooth shown in the radiograph. Which one of the following is least likely complication for this extraction? Question number 10. You're supervising a junior colleague who is extracting an upper first premolar tooth using extraction forceps. Which one of the following movements is most likely to cause root fracture? Question number 11. Your patient requires a surgical extraction of a retained root of a lower second premolar. You plan to raise a buccal mucoperiosteal flap followed by bone removal. When obtaining an informed consent, which one of the following risks is the most important consideration? And question number 12, you plan to carry out a surgical extraction of a fractured lower molar. Which one of the following methods is the most appropriate method for bone removal? Question number 13, when using Coupland's elevators, which one of the following precautions is least likely to be applicable? Question number 14, when gaining access to the operative site for surgical extractions, which one of the following factors is least relevant? Question number 15, you're planning surgical removal of a fractured upper molar tooth. Which one of the following is the most appropriate approach? And you'll be glad to know that that is the final question in the extraction quiz. So just to check that you've all got that link to Microsoft Forms, I'll send that again. I'm also going to go back in and send the link to the anatomy quiz. In case you didn't get it earlier, I'm going to resend the anatomy quiz link now. So I'm just going to jump back into the slides and we're going to go into the suturing presentation. Okay, so last year we did a series of suturing workshops. Suturing is obviously a key skill if you're doing any oral surgical procedure, whether you're just taking out a retained root, a wisdom tooth, an apicectomy, or then going on and doing implants. One thing that strikes me is amazing the number of people that's, particularly young dentists, that say that they want to do implants, they want to get into implants, but they're not confident with simple surgical skills, and suturing is the key to good surgery. Now, I always say when I'm mentoring with about oral surgery, The two most important parts of any MOS procedure are the beginning and the end. Planning and carefully taking up a flap. Okay, doesn't matter if it's a small flap or a big flap. Carefully taking up and raising your flap. Take the time to be gentle and do that slowly and meticulously. And then the suturing at the end. If you get the flap and the suturing right, whatever you do in the middle, whether it's a retained root, a bone grafting, an implant, anything, it will sort itself out. The key is the beginning and the end. Anybody that's been mentored by me or works with me in any way, I hammer that home. The flap and the suturing. Okay, so this is a separate workshop now. Where's my... What we normally do is we normally have a workshop where you can practice these. Obviously, we can't do that online, but we've got some videos to let you see what we do. Okay, so a suture is a medical device that doctors and surgeons use to hold skin, internal organs, blood vessels, and other tissues of the body together after they've been severed by injury or surgery. So there's surgical sutures, there's anatomical sutures, and there's geological sutures. Okay, so these basic properties of a suture, that they might seem a wee bit, pedantic, but it's so important that you understand the properties of sutures. If you go into most practices, you say, what sutures you got? It's whatever's in the cupboard, and they'll have a fairly limited surgical kit. I brought a range of the sutures that we use in the practice. And there's loads of different materials, different suture diameters, needle shapes, and they all have a different purpose. So it's important to understand the reasons for using sutures. Now, if you're just doing minor oral surgery, taking retained roots out and the like, then you won't have to have such a range of sutures. But if you're going to go on and look at doing implants or surgery involving the soft tissue, then you need to have a better understanding of sutures. So the perfect suture material should have no tissue reaction. There should easily glide through tissues. There shouldn't be a sawing effect. It should be easy to handle without memory effect. I'm trying to demonstrate how we can show this memory effect. Okay, so this is 4-O-Proline, okay? And I'm going to take this out. And what I'm going to try, I don't know if you can see it, it's so narrow, but when you take a proline suture out, it wants, can you see that? If I put something dark behind it, it wants to kind of like fold, I don't know if people can see that, okay, but it wants to kind of like fold back in itself. This is this memory effect. I don't know if that works. Or maybe better with white. Sorry, my notes. Never tried that before. Anyway, so some materials have got this memory effect where they want to go back to the shape they were at the start. It's a bit like nickel titanium, really. If you think about nickel titanium and fire, it wants to go back to the way it was. Some materials have got a memory effect, okay, and that's not ideal. You want to be able to tie a knot with them. That knot wants to stay in place. They want to have a high tensile strength without breaking, and non-capillarity of moving liquids along the suture, because if you do that, you bring liquids along the suture and you bring bugs along and you get inflammation and infection around sutures. So there's a wide range of different suture materials and sizes, and the suture size is denoted by the number of zeros, but a 3-O suture, 4-O suture, 5-O suture, and I'm sure you all know that a 3-O suture is wider than a 4-O suture, which is wider than a 5-O suture. The more zeros, the smaller the size and the less tensile strength. So there's a whole, obviously we're just using them for minor oral surgery, but sutures come in a whole range of sizes. So in oral surgery and implant and periodontal surgery, we use between 3/0 and 6/0 sutures. We'll use 6/0 Cerulon. This is what I use when we're doing kind of soft tissue work with implants. My go-to suture is a 5/0 suture. They're here somewhere. We've got 4/0 sutures, we've got 4/0 Prolene, we've got resorbable sutures. But the suture that I use 90% of the time is either 5/0 Prolene or 5/0 Cerulon, and we'll speak about that more. You probably find in practice for general oral surgery, for retained roots, then a 4/0 material is what I would use if I'm taking out a wisdom tooth or doing a simple surgical extraction. But for implant dentistry, my go-to is 5/0, 4/0 for some oral surgery, and 6/0 for perio soft tissue surgery. So sutures can be classified as either monofilament or multifilament. They can be synthetic or biological or natural, and they can be absorbable or non-absorbable. So the sutures that we tend to use in oral surgery are either monofilament sutures or multifilament braided and coated sutures. The threads have different structures, different being monofilament and multifilament, and they have advantages and disadvantages. A monofilament has a low capillarity. They don't tend to have that wick effect where saliva and bacteria are spread along it. Multifilaments will do that. Monofilaments have a lower swelling effect. Multifilaments have a higher swelling effect. Monofilaments have a lower knot security. Multifilaments have a higher knot security. So a multifilament, so something like black silk, for example, it's easier to tie a knot in black silk than it is with the Prolene. And when you start to use monofilament sutures such as Prolene, it takes some time to get used to it. And monofilaments have a lower knot pull tensile strength, whereas multifilaments, you can tie them tighter. I wish I could do this hands-on, but obviously that's not the case. Just a quick, so can we just use, Alan says, use Prolene for the first time the other day, chase the end of it with my forceps for an edge. It's springy, it's a hair curl, white behind, please, can see. So just, you're obviously all seeing this okay. So monofilament sutures are more resistant to harbouring microorganisms. Multifilament sutures are less resistant to harbouring microorganisms. I use, as I said, 5/0 Cerulon, which is a monofilament suture. There's hardly any tissue response around it. It's a fantastic material. The only issue is that the ends of the sutures can be a bit jaggy, and the patients don't like them as much. But if that's their only complaint, then that's great. You just say to them, I know you don't like them as much, but you've healed up really, really well. And when you start using monofilament sutures, it makes such a difference to healing. Patrick, we're going to come on to that in a minute. So I'm going to tell you what Vicryl is in a minute. Let me come to it. So monofilament, advantages of monofilament sutures. They have smooth surface, they have less tissue trauma, they don't harbour bacteria, and they don't have that capillarity effect. Anybody wanting to guess whose head that is? So any guesses as to whose head that is? You can let me know in the questions and answers. And that was an epidermoid cyst that came out of here. So they use monofilament sutures, good handling and knotting. Yes, yours. Next time I get one of them, Farhan, you're doing it. Disadvantages, they're more difficult to work with if you're not used to using them. The ends, knots in the suture can bury. It can be more difficult to get them out. and that can be a little bit more tricky to remove than multi-filament sutures, and they can be a bit stretchy. So different materials have different strengths and weaknesses. Multi-filament sutures, the advantage is that they're strong, they're soft and pliable, they're easy to handle, and it's easy to tie a knot in them. The disadvantage of multi-filament sutures are that they harbour bacteria, they have a capillary action, they can cause tissue trauma. So synthetic versus natural. Synthetic advantages are the non-absorbables, I think are inert. Absorbables resemble natural substances. That title's wrong. They absorb by hydrolysis. They've got predictable absorption and strength. Can quickly jump through that. Okay, so biological ones have advantages over knotting and handling, and they're cheaper. They have tissue reaction problems. Some of these will only really become apparent when you start using them, or even if you had the hands-on. So what we're going to do at the end is, and in the feedback, is there'll be an opportunity if you're wanting to do follow-up hands-on sessions, then we can kind of arrange that. Today was originally meant to be an NES symposium. Shout out Cullen, happy birthday. Happy birthday, Cullen. Today was meant to be an NES day where we're going to do hands-on with suturing and models. But what we'll try and do is to have a follow-up once the whole coronavirus thing has settled down. Then we will do a follow-up with hands-on. At break time, my wife said that Boris Johnson has got coronavirus. Did anybody hear that at break time? Anyways, going back to that, so absorbable sutures are broken down by the body and there's no foreign body left. Disadvantages that they don't support the wound so absorbable sutures, after about 24 hours, they lose half their tensile strength and they don't support the wound as much. So that's a disadvantage of resorbable sutures. So non-absorbable advantages are they provide permanent wound support. You have to take them out, unfortunately, later on. That's time to take the suture out, and you can have a sinus or an extrusion if they're left in place. So examples of absorbable sutures are catgut, chromic catgut, and FastGut, which we don't use in dentistry and oral surgery at least. Synthetic PGA and polylactic acid, which we do use, and absorption times are between 10 days and several weeks. So somebody asked about Vicryl. It's a question in the quiz that's coming up, and it's a PGA, synthetic absorbable material. So absorbable sutures, natural ones are absorbed by resorb by enzymic degradation. Synthetic ones absorbed by hydrolysis and cause less tissue reaction. Non-absorbable sutures are materials such as silk, polypropylene, polyester, nylon, and PTFE. So looking at needle shapes, needles and sutures come in different shapes, different and different fields of medicine. They use it in surgery as well. So in dentistry, we tend to use 3/8 circles and half circles, but they use straight needles, quarter circles, a wide range of different needles available. And you can see this just shows that different needle shapes are used in different fields of surgery. And you can see that we tend to use a half circle or a 3/8 circle needle. I've had to leave a few patients with Cerlon sutures. Not sure how long. I'll try and have a look at that. I'll come back to that. It's quite a difficult question to just answer on the hoof. So the anatomy of a surgical needle. Okay, the key bits to know are the swage. That is where it joins the suture. the needle body and the needle point. If you've lost the connection, just click the refresh button and it will come back. So refreshed. So if you lose the connection, just refresh, and it'll come back on. So you hold your needle, okay, a third to a quarter of the way around from the swage to the needle body. So I'm going to show you, just bring up the thing. So you're going to use your needle holders to hold the needle just about, hang on, here, okay? Right, little hobby horse coming up, okay? A lot of people have got surgical kits and they have got artery forceps, okay? These are artery forceps, they've got serrated edges, okay? These are not needle holders. You don't have to have expensive £100 suture needle holders, but these have got much finer, different edges, and they will not damage the needle. If you use these artery type forceps, they will damage and bend the needle. So make sure that you're using the right instruments to hold your needle, okay? Do not use artery forceps for holding needles. That's not what they're for. Make sure you get tissue holding needles. We've got, on the hands-on courses, we use disposable surgical kits. They cost £3. So you can get needle holders, tweezers, and a set of scissors, wherever the scissors are, okay, for £3. And what I'll try and do is get you a link to that as well. So you don't have to go out and spend lots of money to get fancy, expensive needle holders, but you do want to be using needle holders and not artery forceps to hold your needles. Okay, so there's different companies supply different sutures. The two that you'll probably have heard of are Ethicon. So these, some of the materials that Ethicon use are Vicro, okay, which is a resorbable suture. So that's 4O Vicro, and we've got 4O Prolene here. So they're made by Ethicon, and Cerilon, which is the slide that we've got here. You can see we have 4O, 5O, and 6O Cerilon. Cerilon just handles, it's similar to Prolene, but I find that it handles more easily than Prolene. It doesn't have that memory effect. So Cerilon is softer and more pliable compared with other monofilament sutures. So if you are going to start using a monofilament suture and you're not used to that, I maybe suggest looking at Cerilon. We get it from General Medical rather than Prolene. People may have heard of Prolene more. Thank you, Martin, for sending that Sky News update. So I'm like, the country is going to be run by somebody in isolation. So Cerilon, it's just easier to use than Prolene, and I prefer it. So some rules of thumb: so use the smallest suture that will hold the tissues together. Never suture under tension. If you need to use tension relieving incisions, now that's not something that I can demonstrate without doing. Prolene is a brand of Ethicon, okay, just like Cerilon is a brand of company Serag Wiesner, okay. So Ethicon, Prolene is a brand, okay. You want to do equal, again, this is something you really need to do hands-on for, so I'm sorry, kind of do lose a wee bit of it here without the hands-on, but equal bites on either side of the wound. The sutures should lie perpendicular across the wound. Knots shouldn't lie over the wound, they should lie on the side, and I'll show that in the videos. And the sutures should be placed equally along the wound. On the packaging, just so you understand, there's various information there, so you can see that sorry, that's back to front because of the camera. But all the information you'll find on the side of the box of sutures and also on the suture itself. All that information there as well. So it tells you about the diameter, the needle, all these kind of things. Would you suggest needle diameter for oral mucosal suturing? So as I said, I use for implant surgery, and my go-to suture is 5-0 monofilament. For periodontal soft tissue surgery, 6-0, and for oral surgery extractions, 4-0 sutures. Okay, that's what I recommend. I'm just going to come on to needles in a wee minute. So surgical instruments, again, you can spend a lot of money on instruments, or you can spend not very much money. As I said, we have disposable kits that we use on hands-on that you can get, and they're like literally £3 a pack for tweezers, scissors, and needle holders. So if you want to practice, I'll send you a link and you can buy these and throw them away. We've got, if you're in a practice and if you're an associate, most of you are associates in practice, it might be an idea if you want to spend a little bit of money investing in your own surgical kit. So I have a couple of kits. Gurjit, I'm just coming on to that. The answer, reverse cutting always. So we have, I've got implant kits. I've got kits that I'll use for general surgery, and I've got instruments that I'll use for periodontal surgery. If you want to get serious about oral surgery, invest, even if you're an associate, invest in a surgical kit. It's your kit, it belongs to you, but you want to have some instruments that allow you to practice the skills that I'm telling you about today and that you're going to want to develop. Okay, I know that my principal now, who not so long ago was my VT and associate, he bought his own surgical kit when he was an associate, and he took that with him when he had his own practice. Another bit of advice: if you buy your own kit, don't let everybody else in the practice use it and damage expensive instruments. So if you're going to invest some money in a surgical kit, then do that. You can get instruments, Hugh Feedy, anything from Henry Schein or any of the suppliers. Just in case people want to practice, you can get suture kits for £30. You can actually get it for £3. Okay, so use of needle holders. As I've said, you want to use needle holders and not artery forceps. You want to ensure that your needle holders hold the needle about 1/3 to 1/4 of the way around on the body of the needle, not on the swaged end, not on the tip. The needle should pass through the tissue using the geometry, the shape of the needle should allow it to pass through, okay? So use the shape of the needle to help your suture placement. There's lots of different suture techniques. Can you send pictures of what you have in your surgical kit, including your handpieces? Yes, what I'll do is I'll get that sorted. I'll send these, I'll email any of the information I've not included, such as where you get the £3 surgical kits from and the surgical kits. I'll take pictures and I will email everybody that information over the weekend. No, I mean the pretend skin pads. Yeah, sorry. Yeah, you can buy this kind of stuff online. So the skin pads you can buy online to practice. Just buy it from, Google it, and you can buy these. They're superb. The only thing I would say about the foam skin pads is it's actually harder to suture on these because they're foamy and they're not really like skin. Okay. Again, in hands-on exercises, we'll use pigs' heads, so that's another option. I promise we will try and arrange hands-on workshops as soon as the coronavirus situation sorts itself out. Okay, so suture techniques. The 3 that I want you to there's two that you must be able to do. Every dentist should be able to do a simple interrupted suture and a horizontal mattress suture. And the reason for that is they're the kind of sutures that you need to be able to do if you're managing bleeding. Okay, see, everybody needs to be able to do a simple interrupted suture and a horizontal mattress suture. I'm going to show you a continuous interlocking suture. I don't expect that unless you're doing oral surgery, implant dentistry, that you're going to use that, but I'm going to show you how to do it. Other sutures that are useful are modified vertical, vertical mattress sutures, modified vertical mattress sutures, simple continuous sutures, figure of 8 sutures, and sling sutures. So some of these you're not going to use, but the two that you must be able to do are a simple interrupted suture and a horizontal mattress suture. So hopefully you'll see the videos and then you'll come on a course or get some mentoring. It's amazing the number of dentists that can't suture, and that's no criticism of the dentist. Something else that I found over the years mentoring people doing implants is that they can all drill a hole in the bone and put the implant in. If you've got bone, you can drill a hole and put an implant. It's not that difficult if you've got bone there. Getting the flap up and putting the sutures in are the bit that they sometimes find very, very difficult. And that's an indication that they're wanting to do implants, but they don't have the basic surgical skills that you must have. So raising a flap and putting sutures in are essential skills. So simple interrupted sutures, these pictures are obviously on skin and not intraoral. So the simple interrupted suture is the most commonly used technique in wound closure. It's simple and derives its name from the individual sutures are not connected. They are easy to place. They have high tensile strength. Individual sutures can be removed without jeopardizing the closure. They take longer because you're doing individual sutures than continuous simple or continuous locking sutures. So if you're experienced and you're doing a long, closing a long incision, then these will take a wee bit longer. But you know, for 99% of you, that's what you're going to be using. Each suture requires its own knot, and the more knots you have, the more risk of infection, particularly with multi-filament sutures. So simple interrupted sutures, again, this is what you're going to use if you're doing a single tooth extraction, or a biopsy, or an implant. They're the most commonly used, and they don't bring the wound surfaces into contact, and they're less supportive for healing of flat margins. Don't worry about that. It's your basic suture. I'm not going to get into inverting and everting wounds. That's where you might margins. That's where you might want to be using vertical or modified vertical sutures, etc. You should all be able to do a simple interrupted and also a horizontal mattress. Okay, and in fact, that's a wisdom tooth that I did in a practice. It's a simple extraction, no bone removal. All that was there was we used Resorbable because the patient wasn't coming back. They were going on holiday or something. So a reason for using a Resorbable suture is the patient's not coming back. There was 3O Vicryl and just a simple interrupted suture there after that extraction. Horizontal mattress suture, this is the second suture that I want you to be confident doing, okay? The horizontal mattress is a square-shaped suture with a knot lying parallel to the wound. Do you need primate closure after extraction? Something, I'll come back to that one. The horizontal mattress is a square-shaped suture with a knot lying parallel to the wound. It's useful in wounds, tension, and to help evert the wound edges. It's good, excellent at after post-extraction, and it's excellent for achieving hemostasis. Okay, so the horizontal mattress sutures, the reason I want you to know that it's good for managing sockets after extraction, and it's good for hemostasis. Also, it's a kind of basis if you want to go in and do a figure of 8 or kind of crisscross type suture. If you can do a horizontal mattress, which is a square, you can then do a kind of crisscross, and you can go on from there. It's just a modification of it. Vertical mattress, I'm not going to demonstrate or show you a video of that. It's good, and it everts the tissue edges to allow for improved healing. We'll use it where we're suturing into dental papillas and for crown lengthening, but I'm not going to dwell on that. Some of these other sutures. There's various modifications of the vertical mattress suture. Continuous interlocking suture. You can see here there are just 2 knots. So if we bring the whiteboard up. So you've got 1 knot here and 1 knot here. Okay, and you can see these are used in situations where you've got long incisions. And one of the advantages of these is because there's not lots of knots, okay, then it's faster to do because you're not tying it and then snipping, tying. You just go loop, and walk. With a continuous suture, you can either do a continuous suture or you can do a continuous interlocking suture. The interlocking is better, and if any of it breaks down, the whole thing is more supportive of the wound. We'll show you the video of this, but you start with a simple interrupted suture here, and then you go along and you lock and you lock and you lock and you lock and lock and lock. Sorry, I'm just doing that with the mouse. So you get the idea. Oops. Okay, so continuous interlocking sutures are used along the wound. They're used for longer incisions. They're quicker. They're more watertight. The wound is of greater risk if the suture material breaks. There's not if you're using interlocking. It's a bit like the Sunday roast suture you might see when you have your meat from the butcher on Sunday. Periacryl, you can highlight in the situations where you can use tissue glue. It's an intraoral version of the stuff. If you're falling cut yourself, if your kids go to hospital and it doesn't really need sutures, they can sit and glue over it. You can get that for intraoral use as well. So in the practical, which we're not doing today for obvious reasons, we would have demonstrated simple interrupted sutures, horizontal mattress sutures, and continuous interlocking sutures. At this point, I'll just jump out into videos. So I'm going to start with a simple interrupted suture. Okay, so this is a simple interrupted suture. Okay, again using the foam pads. Okay, so bites. Now you've got a tail and you've got a loop. Now put your instruments in, wrap your two throws over. Now the key bit here, and this is the take-home message on suturing, is that the short end swaps sides and that you get a flat knot. Your first knot needs to be a flat knot. Okay. And then your short end, which goes from side to side, you see what I mean here? So your short end is at the top, and then your short end goes to the bottom. Okay, and that is the key to suturing. Okay, flat knot, and then the short end going from side to side. I'm just going to show you that again, because I really want us to stress this. So you can see you're going to have a short end, a tail, which is at on the top side of the wound. So 2 throws, and then your tail swaps to the other side. As long as you have your tail swapping from side to side, you're on a winner. You get a flat knot, the wound closes, and then your tail, which is in the bottom, 1 throw over, goes to the top, and your tail on the top goes to the bottom. And then the other thing you want to do is to make sure that the knot is moved away from the side, from the wound, so it lies at the side of the wound. Okay, just to show you that this is child's play, where's the video? My daughter, we did this a year ago. So, Miranda was 12 at the time. So we're getting ready for the shoot. So we're getting ready for the suture workshops at the Scottish Dental Show. We're just at the kitchen table, and we've got Miranda, who's 12, who's going to demonstrate a simple interrupted suture. I explained to Miranda how we did it, and she's going to demonstrate this for us now. Okay, on you go, Miranda. So you've done your first bite, yeah? Mm-hmm. Take the suture through. So that first bite is 3 millimeters from the edge of the wound. That's good, and if you pull the needle through. Well done, Miranda. So we're practicing on suture pads, which are meant to represent skin. In the minor oral surgery workshops, we'll be using pig's jaws, which are far more like the real clinical situation in the mouth. But we're using suture skin pads to practice with this evening. So Miranda, if you can do the second bite now. So again, 2 to 3 millimeters from the edge of the wound, and pull the suture through. And again, here you want to make sure you don't get. So you're going to do your first knot, Miranda. Okay, so you want to leave the short end. Okay, so you can see the short end's away from you, and then you're going to go round once, twice. So what I was just bringing, that's it, and then you grab the short end, grab it a wee bit further up, closer to the end. Your tail was your short end was a bit too long there, but you just pull that through, and then swap sides, and then and then pull it through. So what you want to see is a flat knot. That's perfect. That's good. So you want to tie it firmly, but not too tight. Okay, if you tie it too tight, you get a scar. Okay, that's good. Okay, now your short end is on your side, and this time around you're going to go once towards you, and then the short end swap sides away from you, and then you tie this down. Okay, and then you're going to go with the short end, which is away from you, once, and then the short end swap sides. So the key thing is that the short end swap sides. And then where do you want to make sure the knot lies, Miranda?
Not on the wound.
Not on the wound, that's right. So you want to make sure the knot lies on the side, okay, away from the wound. And if you just use your scissors now to cut the ends. Well done, Miranda. What are you gonna do with the needle once you're finished with it?
Put it in the sharp spin.
That's it, okay. Oh, there's a bottle of beer beside the sharp spin. We don't have that at work. So well done, Miranda. Nice suture. So that's us all ready for the suture workshop at the Scottish Dental Show on Friday and Saturday. Thank you. Excellent. So as I said, suturing really can be child's play. What I'm going to do now is to show you a horizontal mattress suture, and then we're going to do a continuous interlocking suture. So you can see here using 4-0 black silk. It's easier to see, and you can see that we've got a kind of square shaped. So you've got the bites going through and they're equidistant on either side, 2 to 3 millimeters from the wound margin. And you can see there that we've got a square shaped knot. And then we put our instruments. Remember what we said before, that the short end swaps sides. So the short end is going to swap from left to right. And again, you've got that flat knot that we spoke about. Okay. And then the short end is on the right hand side and it swaps to the left. And then you've got the short end is on the left hand side and it swaps to the right hand side. So that, again, that key thing where your tail swaps sides is really important. Okay, and finally, I'm going to show you the video of the continuous interlocking suture. Okay, so the continuous interlocking suture, you start just with a simple interrupted suture. Okay, so you just start as normal with a simple interrupted suture. And at this point, you cut the tail. And then you start feeding your loops through. Okay, now with a simple continuous suture, you just keep on going in loops. With a continuous interlocking suture, you pass your needle back through the loop, and that's how you get your lock. Okay, and then you go again, another bite, and then your needle through the loop, and it locks. And you just keep repeating it, and you go along and along and along. So a simple continuous suture, you don't do the lock. With a locking one, you put the needle back through the loop, and that's how you create your lock, which supports the wound more. And then once we get to the end, we will show you how you tie it off. Some people get a wee bit confused about this because there's no tail. You're normally used to tying a suture off against a tail, but you don't have a tail, so how do you tie it off?
What was it?
So you keep on going, just repeating, bite, needle through the loop. There's different ways of doing it, but this is quite easy to see. So bite through the loop. And then at the end, you don't have a tail. So what you do is you tie off, and just watch this. This is where you might not have seen this before. So with no tail, you don't have a tail to tie off. But you tie off against the loop. So you leave a loop, then 1, 2, and rather than grabbing a tail, you tie off against that loop. Then the loop again. This time it's the loop that swaps from the top to the bottom, and then the bottom to the top. So you're using the loop to tie off to finish your continuous locking suture. So you can see there you've got 2 knots and the continuous interlocking suture. Okay. Okay, we're in the home straight. We've got less than half an hour to go. The reason I know that is that I put enough money in the meter to get me for another 29 minutes. So, just to mention, this is a fantastic book. on suturing. So I could recommend that. I'll put that on the handout. Or not the thing, I'll email it to you. Okay, so one more quiz. Sorry, peeps. Okay, here comes the link to the quiz. Okay, so you should all have received the link to the quiz in the messaging chat bit. So you can click on the quiz. You can either do it now or a little bit later. Just a few messages. Has everybody got that and is starting to get into the quiz? Yes, Ali, you've got it. Everybody else got it? Okay, no, the link's there. Ali, got it. Okay, here we go. Right, so question number 1. What type of suture material is Vicryl? Is it absorbable synthetic? Is it absorbable natural? Is it non-absorbable synthetic? Or is it non-absorbable natural? So what type of suture material is Vicryl? Absorbable synthetic, absorbable natural, non-absorbable synthetic, non-absorbable natural. Question number 2, what type of suture material is Prolene? Is it absorbable synthetic, absorbable natural, non-absorbable synthetic, or non-absorbable natural? Okay, so what type of suture material is Prolene? Question number 3, you probably don't know this one, but just guess. Which of the following tissues would be most suitable for a non-absorbable suture? Right, this Ferran, this is for you. This question's here just for you. Which of the following tissues would be most suitable for a non-absorbable suture? Bowel, stomach, tendon, or bladder? What a disadvantage of multi-filament sutures? They are difficult to handle. They have poor knot security. They provoke a greater tissue reaction. They have a higher infection risk. So what's a disadvantage of multi-filament sutures? They are difficult to handle, they have poor knot security, they provoke a greater tissue reaction, they have a higher infection risk. I'm resending the link, so it's definitely coming to you. What I'm going to do is, I'm not going to do I don't have time to do the answers to these. I will email the link to you all. So I'll email the links to the quizzes. And what I'll probably propose to do is a 1 hour quiz follow-up next week, so you've got time to do it yourself. Okay, question number 5. Which of the following is a synthetic suture material? Silk, nylon, catgut, or steel? Which of the following is the smallest suture diameter? 1/0, 3/0, 4/0, or 7/0? And where should a needle be held by needle holders? The needle point, the swaged end, the needle body, or the suture should never be held. Question number 8. You have carried out the extraction of an upper right first permanent molar tooth in your patient. You're concerned about post-operative bleeding and intend to place a suture to aid hemostasis. Which of the following is a most appropriate suture in this situation? A, buried intramucosal suture. B, continuous suture. C, horizontal mattress suture. D, simple uninterrupted suture. or E, vertical mattress suture? Question 9. You have carried out a surgical extraction of a lower second molar tooth and now you plan to close the flap. Which one of the following would be most appropriate suture for this purpose? A, 2O Vicryl, B, 2O silk, C, 3O Vicryl, D, 3O nylon, E, 3O Prolene. Question number 10. Following a surgical extraction of a lower molar tooth, you have closed the flap using a black silk suture. What is the most appropriate time for suture removal? A, 1 to 2 days, B, 3 to 5 days, C, 5 to 7 days, D, 7 to 10 days, E, 10 to 14 days. Question number 11. A 12-year-old child presents to you with facial laceration of the right cheek. Which of the following would be the most appropriate suture material for closure of the skin? A, catgut, B, Dexon, C, Prolene, D, silk, E, Vicryl. And last question. You plan to carry out the surgical closure of an oral antral communication with a buccal sliding mucoperiosteal flap. Which one of the following factors is most likely to increase the risk of dehiscence? A, flap with bilateral releasing incisions, B, lack of postoperative antibiotics, C, tensions across the wound margins, D, use of local anaesthetics with a vasoconstrictor, E, use of a non-resorbable suture material. Somebody's asked for the Just Giving site, so I'm just posting that again. So you'll all be glad to know that that is the last of the quizzes that you need to do. So just going to go back into the slides. Okay, so this is a hands-on course I've kind of tried to use with without Pig's Head, so it's not really going to be ideal, but I'll go through it anyway. Okay, so as I said at the beginning, one of the keys to successful MOS is good access, suction, lighting. You want the flap design, carefully raising the flap and closing with sutures are the key to success. The extraction, bone removal, implant placement will sort itself out as long as you have a good flap design and put everything back together with sutures. So flaps up, mucoperiosteal flaps, there's different designs, envelope flaps, two-sided flaps, three-sided flaps. Something that's important to understand, whatever design of flap, a big flap heals as well as a small flap. Access and vision are the priority. In fact, it's better to take up a big flap so that you can have better access and better vision rather than trying to have a small flap and then not having good access and vision. Your incisions should be over sound bone, so you shouldn't be doing an incision over a cyst area. The wound should always be closed tension-free with a periosteal release and or for bigger wounds, mucosal release. The suture should be closed from the mobile flap to the fixed tissue. Principles of flap design. The flap should carry its own blood supply. It should allow surgical access to underlying tissues, can be replaced in the original position, or can be maintained with sutures and expected to heal. And we use it in oral surgical, periodontal and endo procedures to gain access. Complications of flaps: flap necrosis, flap dehiscence, flap tearing, injury to local structures. Then, so flap design principles: the incision must be made over intact bone. Okay. So no incision over a infected area with the bone missing underneath it. If the pathological condition has eroded the buccocortical plate, the incision must be at least 6 to 8 millimeters away from it. The incision is to be 6 to 8 millimeters away from any bony defect created by surgery. Gently handle the flap's edges. Don't place the flap under any tension, and avoid crossing bony prominences such as a canine eminence. Remember back at the start when we were doing that, when there's that slide of the maxilla where we showed the canine eminence. Don't put an incision over the canine eminence. It's difficult to suture there. So principles of flap design. The base should be bigger than the free margin. This is to ensure that you preserve an adequate blood supply, unless a major artery is present at the base. The width of the base should be greater than the length of the flap. It's less critical in the lower cavity, but the length should be less than the width. A long straight incision with adequate flap reflection heals more rapidly than a short torn incision. So that's another way of saying big flaps heal as well as short flaps. Blood supply is in the base, and hold the flap with a retractor resting on intact bone to prevent tension on the flap. Again, these are all things that it's easier to communicate when we're doing hands-on with pigs' heads, or to demonstrate. So different flap designs, mucoperial periosteal flap designs, 2-sided, 3-sided envelope flaps. You can see, if we go back to the pictures that I showed you at the very beginning, and this demonstrates very, very clearly how the incisions are very, very far away from the radicular cysts. So you don't want your wound margins over or close to the defect. By carefully raising the flap, by doing careful surgery, we've managed to put the tissues back together again to promote ideal healing. And that patient came back in, although he had what you might think to be quite a major procedure, removing the granulation tissue. We did some GBR, healed up very, very well. And the key to that is how you handle the tissues and how you suture up afterwards. If you raise the flap well and suture well, they're removing the cyst bit, they're doing the implant, they're taking the root out, will sort itself out. Again, remember your anatomy from the beginning. No vertical relieving incisions where you've got anatomical structures such as the mental foramen. No vertical incisions in the palate, and that's absolutely essential because you've got vessels that can cause serious bleeding in the posterior region, and they come forward as far, the palatal vessels can come forward as far as the distal of the carines. Bone removal, again, we had Kirsty Payton at Dentsply Sirona had organised 20 NSK surgery promoters, so you could all practice on models to remove bone. Our go-to surgical kit is the NSK Surgery Pro, and that's what we use for both removing bone. We've got piezo surgery. You can use a straight hand piece on a slow speed motor and squirt saline on. It's not ideal, and if you're doing only the occasional surgical extraction, it's acceptable. Debate about using high speed. We will use high speeds to section roots. I'm quite comfortable sectioning roots so that we can elevate the roots out individually. Okay, but I don't use high speeds for removing bone. So I'm getting messages from Webinar Jam that I've got 10 minutes left. So at this point, we've obviously covered a heck of a lot of ground. Sorry I've not been able to answer all the questions because there's just too much, there's too many people. We've still got 540 people, and I can't answer everybody's questions. What I'm going to do is, rather than send the CPD certificates out straight away, I'm going to do the feedback. I'm going to send out the all the quiz links again, so that if you've had any issues, then you can do them on your own time. I'll maybe follow up with a quiz answer session for everybody that was involved today. I mentor, support and encourage all my colleagues